Yes, sir.
Good morning, everyone. This vibrant Sunday morning, we are going to learn something different as usual. I hope I'm audible. My Rehab Academy, as you know, this doesn't need any introduction when it comes to the training for our fraternity. Today's topic: differential diagnosis, assessment, and treatment by Dr. Umarfarooque Khan sir. He is a well-known osteopath. He is a chiropractic. Obviously, he's a physiotherapist, but along with that, sir has these specialities, and it was a great demand from our members to get the course on uh, back pain. I mean, low back pain, differential diagnosis, how it has to be done. I was getting personal mail. I was getting personal messages every month, minimum 10 to 15, sir, when it is happening. So today we are on it. So all of you kindly switch on your video and continue with the course. Before that, I would like to make certain announcement that our courses you can always check on our Facebook handle as well as other social media handle, and you'll be getting the notification in your group as well. So it was a very successful last Sunday. The sport econ recordings are available at very nominal cost. Kindly message me or CEO sir or like obviously the Academy's 24/7 number, and you will get access to that. It at very nominal cost, and for our members especially, it is available. Sports econ, it's about 7 hours of recording. Yeah, 6.5, 7 hours of recording, and it's having about 8 vibrant topics, which actually are very very important for all kind of physios, right from budding to experienced. So I think Dr. Umar Farooq sir has joined, and he has shared his screen as well. Sir, you can go ahead. It's all yours. So candidates, kindly switch on your video and continue with your video. I expect about 125 to 150 to join. So those video will not be on for more than 80% of time. Let me tell you, their certificates might be on hold. So that time it won't be having any kind of conversation regarding the certificate. All the certificates will be issued for those people who will be with the event for any time during the event, but will be with the event. So be careful and continue with the event and learn, enjoy with us. Thank you so much. All yours. Dr. Umar Farooq, sir. Sir, are you able to hear?
Yes, yes. Good morning, everyone.
Yeah, you can increase the little audio of your gadget, and then yeah, you are able to. Yes, you can make a full screen, and sir, you can go ahead, sir. Somebody
Just
is asking why do we have to turn on our cameras. Let me tell you why I'm telling always the video has to be on, because sir wants to interact everybody, at time to time. Number one, important to see like how much you are, because people are there who will be doing other work and they'll be just learning the session. So that is not correct. When you are giving time to something, you should be on always. Thank you so much, sir. Go ahead, sir, please. All yours.
good morning, everyone. Thank you for joining on Sunday morning. Today, we are going to see one of the common topic and common problem is that is low back pain. And thank you, my Rehab Academy, for giving me an opportunity to be in front of you. Thank you so much. So, what we are going to see is a basic of functional anatomy. What could be the different type of low back pain? What should be their symptoms? How to diagnose them? And a brief in treatment. See, for being a good physician, a good physiotherapist, a clinician, we should be thorough in at least four conditions. One is low back pain, neck pain, shoulder, and knee joint. So these are 4 5 conditions. If you are good in that, you can cover your 80% of your patients. So no, I'm not here to teach you the basics of anatomy, but just to refresh our anatomy. So this is how the pelvic look like. We have ilium, ischium, pubic, and a brief about the lumbar vertebra. You can see the body, the spinous process. Okay, and how they are aligned with each other and with the pelvic, and most important. So for us, for like a surface anatomy or palpation method, we should know where is the spinous process, mammillary process, and lamina, which we can be palpate on the posterior aspects. So what's common thing is um, thing to see for us is the spinous process, memory process, and lamina, where we can see the alignment, whether the spinous process is anterior compared to the other, or more posterior compared to the other vertebral level, or it is rotated to the right or left, or it is even tilted, can be felt by the spinous process, as well as lamina will help us in uh, as well as the transverse process will help us in observing the rotation of the vertebra, whether it is rotated to the right and left, and that is very good, great help from manual therapy point of view. So to read an MRI, also we should be very well aware with the anatomy. So this is how the normal disc and the herniated disc will look like. Okay. So we don't see that. Commonly, we don't see the MRIs in a detail, but from manual therapy point of view, looking the MRI and X-ray give us lot many detail. Especially if you are interested in chiropractic, then MRI will be great help for you if you read them from a chiropractor uh, point of view, or how the chiropractor read the MRI. So here you can see this is an MRI of lumbar vertebra. You can see the body, the spinous process, the transverse process, facetal joint, and the roots, nerve roots existing right and left. So in this, what if you want to be a thorough in a chiropractic, so you can see this screen. The spinous process is straight, whereas where it is written a normal central canal, the spinous process is rotated to the right side. So this is the difference between a MRI reading of a physician, of a radiologist, and of a chiropractor. So I am more of interested in the slide where it is they have written normal central canal. If you see the spinous process, the tip of spinous process is little bit shifted to the right, and that's how when you are going to palpate the transverse process, one will be felt, the left one will be felt more posterior than the right one. So we are interested in the alignment of transverse process also, because that is where we are going to correct it. And then how the facetal arthropathies will see, how if the disc root comes, then how you can see the severe spinal canal stenosis. Uh, we should be able to see the cause of spinal canal stenosis, whether it is a ligamentum hypertrophy or disc, or a rotation in the spinous process. So if L4 is rotated to the right, there are high chances the L5 will be rotated to the left. And this rotation also can create the spinal canal stenosis. Simultaneously in X-ray, where you can see the L5 is posterior to L4. So we'll call as a retrolisthesis of L5 over L4. These are important for manual therapy. See, there is no pars fracture. That means this patient is not require any kind of surgery, and we can very well treat that patient with manual therapy and chiropractic. That is what the rotation I was saying you. This rotation from manual therapy point of view are very important. In a further class, we can see how we can correct and how to read the rotations. So this is how the PIVD will look like, and so you can see the transverse, the thickle sac, and the roots, right and left roots coming from the L5 disc. And there are few muscles before going to for any clinical things. So few important muscles of the lumbar spine and the lumbo-pelvic region should be aware of is iliopsoas. You know, they are hip flexor, but they are very what they can cause is rotation at the lumbar spine, the spinous process. They will help in lumbar flexion also. But if the iliopsoas is tight, what they will go, they will rotate the vertebra at local level, L4, L5, L3, L2. So the tightness of iliopsoas very important for us. The iliopsoas is an important muscle. Simultaneously, piriformis is an important muscle for us. TFL is an important muscle for us. So these are the three more important other than the cordatus lumborum. So cordatus lumborum patient, they will be if the cordatus lumborum tight, the patient may complain of the list on one side. Same, the pain will be felt along the lateral aspect of the back, along the iliac crest, gluteus medius, and it may go and radiate down, and it mimic the sciatic pain. And most of the time, piriformis and cordatus lumborum they are tight all in together, and they leads to the they leads to like features like a cordatus lumborum. Now, from functional anatomy, just one example I am giving you how a small imbalance in your neck or in the ankle can lead to the whole line of disturbances. So if the neck is tilted on the left side, you can see the right side all the neck muscles will become stretched, and then opposite side will be tight simultaneously, or the same side shoulder will be elevated because of that contracted muscle, and your spinal paraspinal spasm will be there on the right side. Hip, the level of hill will be elevated. All the hip muscle, especially glutes, will be tight. Their hamstrings will become tight. The calf muscle will become tight, and that cause the short leg. So, one change anywhere in the body it can be transferred lower down or up above up. So sometimes even a calcaneum muscle malalignment can lead to headache. A small ankle sprain or a calcaneum or talus dysfunction can cause a migraine-like symptoms or headache. Or sometimes if you correct the ankle or correct the calcaneum and talus, the patient will say, "Okay, I was having a low headache since many days, and now after this, the headache has reduced." So small distortion anywhere in the body can lead to uh, any major pain. So that's why nowadays we say okay, body is not divided in segments. It is a unit, and you have to treat the whole body, not just the particular point. Especially this is true for spinal conditions and the low back pain. There are many other examples. Suppose the entire pelvic is anteriorly tilted, excessively pelvic is anterior or forward. It will cause a femoral internal rotation in relation to then tibia will be internal rotated and foot will become a pronated foot. And how this will happens and how this will cause the low back pain, your abdominal muscles will become too weak, hip flexors will become tight, quadriceps will become tight, and in relation to the quadriceps, hamstring will become weak, gluteal muscle will become weak, and there will be thoracolumbar fascia tightness. So this again will lead to low back pain. Why I'm emphasizing on this functional biomechanics more is because before assessing the patient, we should know the correlations of the each other joint. How a weak abdominal muscle can cause a weak gluteal muscle, and simultaneously there will be an anterior pelvic tilt, excessive anterior pelvic tilt, or lumbar lordosis will be increased. So a patient comes and we just release the thoracolumbar fascia, and if you don't and just strengthen the back muscles, it's not going to solve the problem because back muscles were already too tight, they were already hypertrophed. So we want to release the back muscle but strengthen the abdominal muscle and gluteal muscle especially. So The reverse will happen if the pelvic is and instead of forward tilting, it will be backward tilting. The femur will be rotated externally, tibia will be rotated externally, and there will be a foot supination. And exact opposite chain of muscles will become weak and tight. So postural assessment give us lot many things, and if you are good in correlating the postural findings to the muscle finding, then it becomes very easy to treat the patient. Hope I am not too fast. You can stop me if I am becoming too fast. Okay. So in a posterior pelvic tilt, what as I'm showing, the rectus femoris will be hypertoned. That means they are overacting, and gluteus will be strong, and again, the hamstring will be strong and quadriceps will become weak. So, as I said you earlier, a well aligned spine connects the brain and body function via uninterrupted nervous system. So, body and brain, if they are connected very well, then there will be ease. And a malaligned or misaligned spine cause disruption of the nervous system. So body and brain, they are not connected properly, and this leads to dis-ease. That means any kind of low back pain or back pain, neck pain. So this is subluxation. This is a concept very common in osteopathy and chiropractic. So see again, we here I will just like to emphasize on one point. Being a clinician, our main aim is to make the our patient, our client perfect, to reduce the pain, to reduce the recurrence of pain and make his life easier. So being a physiotherapist, I am supposed to treat the patient without medicines, without injection, without any operation or surgeries, but I can treat the patient with my hands. So if I can give MFR, I can give mobilization, and I can give manipulation. So if I see I can make the patient without giving medications, injections, surgery better, then every other thing are allowed. So we there is always still a debate going on whether we should follow the osteopathy and chiropractic. These are the terminologies just in use. Otherwise, physical therapy is anything which we can give with our hand. And what we are not supposed to give is the any medicines or surgery. But rest we can definitely, it comes in manual therapy only. So coming to the main topic, hope the points till here are cleared. So patient of low back pain can come in any symptoms. The pain can be localized. They will say okay, only when I stand for longer duration time, then only I get a pain. The pain can be centrally or right side or left side. Whenever I turn in bed or sit to stand, I get a low back pain. Uh, Throughout the day, there is no problem, but whenever I go for a sleep, then there is a pain. Either it can be a low back pain, or it will be radiating to one leg or both leg, or there will be only a calf pain or a leg pain or pain in foot. So in sleep, okay, rest of the day, no problem. Then there will be patient will say okay, during walking or after long standing or walking for a longer distance, they get pain in the low back, or it can radiate to right or left leg or both leg, or there will be a claudication. So the main important thing is what you ask the patient, and how much we can get the knowledge from their history. So if the patient says okay, I have more pain in night. Throughout the day, I'm fine. There is no problem. But whenever I go for a sleep, that time I get pain or fear. Then I don't get a sleep properly. There is a problem in constipation. There are problem of acidity. The diet is reduced, concentration is reduced, not able to work properly. So the all our symptoms leads toward more of a stressed body or psychological symptoms than toward any neural or muscular component. So there will be a chances of 30% muscular problem, but more will be a psychological or stress induced. So these are the patients. If any patient has three symptoms: pain in night, especially during sleep, after rest, acidity, and reduced sleep, there are high chances that the patient's symptoms are mainly due to overthinking, psychological, or uh, stress syndrome. So here we need to counsel more. Cognitive behavioral therapy will be great helpful. Any type of meditation, and simultaneously you can assess and release whatever the tight muscles present there. Uh, then, if a patient says, "Okay, I have a pain while rotating, while turning in the bed, right side or left side," if the pain is there on rotation, okay, or sit to stand, but once I start walking, the pain reduces. Then I don't have any pain. It's mainly in turning or sit to stand. Whenever I change my position, there is pain, but once I start walking, slowly the pain reduces. So more of a chance of SI joint pain. Then there is more chance the patient may be having SI joint dysfunction uh, that is leading to pain. So we need to correct the SI joint. Pain after prolonged standing, high chances of a muscular pain, especially QL and gluteus medius tightness on one side can lead to the long standing pain. The listhesis patients, especially if the patient say, "Okay, I'm sit to stand, there is pain," or whenever I'm standing for longer time, standing for prolonged standing, if the pain is more on center and it's going to right and left side, there is a chances of listhesis is there. Or if only on the right side, then there is a chance of a chordatus lumborum or gluteus medius pain. Listhesis, if there is a listhesis, then if you are suspecting the listhesis is there, to diagnose it, you should take an MRI and X-ray, not MRI, sorry. Take an X-ray on epilateral view and side view, or lateral view, especially flexion and extension, because our aim is to see what is the stability of the segment L4, L5. If there we are suspecting a listhesis, then after flexion or extension, how much forward that segment is moving. So if it is stable, then it's your patient. We can treat very easily. But if the stability is not there, the vertebra is excessively moving forward or backward in flexion or extension, but there is no parts fracture, then also we can give a physiotherapy trial or we can correct that joint. But if excessive listhesis with parts fracture, then ideally we should refer to the spine surgeon. If there is no radicular pain or no neural complaint, then also we can avoid the surgery. So listhesis with radiculopathy, with pars articularis fracture, best possible treatment will be to go for surgery. Then working more on physiotherapy and chiropractic. Then there are we commonly patient comes here, doctor, I have a sciatica pain. I have a sciatica. So sciatic nerve any pain going to posterior aspects of the leg, patient terms it, and even most of the physician and doctor they say it is a sciatica pain. So sciatica can be because of many reasons. Either there will be a PIVD at L4, L5 or at the lumbar vertebra, or if going down there is a tightness of piriformis or gluteus medius, or going down further there are other muscle where other level where the sciatic nerve is getting compressed. And everywhere, if because of compression, patient will come with the same symptoms. Okay, my pain, I have a pain in low back and going to the posterior aspect of my leg. So how will you differentiate it without seeing an MRI, okay, whether it is a PIVD pain or a muscular pain or simple piriformis pain? So if patient tell you, okay, I have pain after walking, the pain increases and goes down till calf level, then there are high probability the pain is because of PIVD. But if the patient says, okay, after taking few steps, the pain is there, but as I start walking more and more, the pain starts reducing. Then it is not because of PIVD. The cause will be mainly will be piriformis or some muscular tightness than a typical sciatica pain. So for PIVD, even if an MRI shows you that there is a root compression, but or there is a disc at lumbar level, but the patient pain reduces after walking, then the pain is not because of the PIVD. It is because of the muscular component. So we can explain the patient, I am not here to treat the MRA. I am here to treat you. I am here to treat your patients. So we don't want to correct the MRA, we want to correct you. So if you have pain, if the patient has pain while walking and it increases with the walking, then only the MRA and symptoms are matching. Otherwise, a disc, simply presence of disc does not say that okay, this pain is because of that. Then acute disc will, if yesterday only in my OPD, the patient came with a deadlift. So after deadlift, he's got acute back pain. So there are chances of PIVD in that. But again, if the pain is not going to the back, going to the lower leg, you can always correct that conservatively. So we releases the tight muscle, we releases the tight structure, strengthen the weak, we corrected it, done manual therapy and chiropractor, and in a single sitting also the pain was significantly reduced. So in 4-5 sitting or maximum week time, we can cure even the acute PIVD cases. So, to name a few, we have discussed the SI joint pain, piriformis pain, listhesis, PIVD, psychological, claudication, muscular. There are again n number of other things which can lead to pain, even a tight pelvic floor or weak pelvic floor, especially in a female patient. Post-pregnancy, PIVD, post-pregnancy, low back pain can be there. And most of the time, they say कि because of the cesarean or the anesthesia giver, they are having a low back pain. But the major cause is the pelvic floor muscle weakness and a diaphragm, pelvic diaphragm, which is not working properly. So a simple pelvic floor strengthening will help to reduce most of post-pregnancy pain. So PNC, even in ANC and PNC classes, we should work more on the pelvic floor muscles. We'll take a small break here on women's health. So women health is developing a separate branch very fast. So if you want, uh, see, in India there is very less awareness about the woman health, but in the West the woman health awareness is very high. So nowadays, if you want to diversify your practice, you can work on woman health also. So what could be the line of treatment? For any pain, the basic principle which I follow is I have looked for after diagnosing the cause and everything. I follow the which are the tight fascia and muscles. So release the tight fascia instead of giving stretching. So there is a difference between stretching and releasing. So release the tight fascia and muscle. Give the biomechanical correction. Either you can use, we'll discuss, either you can use a manual therapy, osteopathy, or chiropractic, correct the biomechanical correction, and then give strengthening exercises. So these are 3 point simple line of treatment. So for release of fascia, there are many techniques. You can use advanced machines like matrix resonator therapy, simple MFR, cupping, cupping MFR with cupping. So ISTM. So many techniques to release the tight muscles. Okay. Nowadays we have other modalities also to reduce pain. Uh, the PMF also will help to reduce the spasm, release the tight muscles. Shockwave, deep structure like quadratus lumborum, gluteus medius, very helpful. Piriformis, very helpful in terms of shockwave therapy. PIVD, if there, then laser is good. And nowadays, many clinics are having decompression beds. So decompression beds, if there is a small PIVD or even muscle spasm at a specific level, even the decompressions, it gives excellent results. If patient comes with list on right or left or a rotated spine, that also can be they can be taken care by decompression bed. Now decompression beds, they are coming with not only just decompression but flexion, extension, rotation, and lateral rotation also. There are many more machines. I've just enumerated few. I missed many other machines with many other good machines available nowadays. So I'm not great fan of modalities, but keeping these things give you an advantage over other. That's the main thing basically. Nowadays, more and more clinic physiotherapists are coming in, becoming clinician, and we are coming more of advanced physiotherapy clinics. So we should be more equipped with modalities as well as skills, and simultaneously your marketing skill also. So in my hospital and clinic, we have all of the things which I enumerated. So we have decompression bed, laser, matrix therapy, PMF, shockwave therapy. We use all. So like you have said, कि PI, if the patient comes with SI joint pain, so this is how if stick to stand pain is there, we can just stabilize the SI joint, give 3-4 repetition of sit to stand, then spot marching, and then walking. So this reduces the it in a single sitting we can correct the SI joint problem. Now coming towards some some other form which have added to our skills is chiropractic and osteopathy. If you read the terminologies, they are like a physiotherapy terminology only, and their aim and principles is are same like physiotherapy. Physiotherapy is a newer branch. Basically, most of our techniques are derived from either osteopathy and chiropractic. So you may be aware when IFT was introduced, many people were resisting the IFT machines. You know that in 1990s when IFT was first introduced, so many people were resisting the IFT key. This is not in physiotherapy. Why we are using it? Now, not a single clinic is complete without IFT. And similarly, we have many other machines coming up. So you have to keep updated. You cannot divide yourself कि ये chiropractic की techniques हैं and I cannot practice that or these are not physiotherapy part. Patient will say, okay, tata bye bye. I will go to some other therapist. If you want to be a good clinician, you should be aware of chiropractic and osteopathy. They are and basically we want to cure our patient as early as possible. So if some skills which are helping me in correcting that, then you should never hesitate in learning the new techniques. And in India, there is no chiropractic college. That is, once if the chiropractors comes in the India, then you won't be able to practice chiro. Believe me. In USA, physiotherapists cannot even use a small adjuster, chiropractic adjuster there. Here, since it's not been yet a regulated branch, we can practice. And even though many Ayurvedic, BMS, BHA-based doctors have learned chiropractor and they've done a 1 week or 2 week course and they call themselves chiropractor and they are maligning the profession and even uh, causing other problems to the patients. That's why it is. But believe me, patients come easily for Caro. If you market the Caro, patient comes easily if you market the physio because at present more people are becoming fan of chiropractic. So I'm not saying you should stop physiotherapy, saying yourself a physiotherapist. We are physiotherapists, but you should know few skills of Chiro also, which are good. So these are the founders, Dr. D.D. Palmer. He he has introduced the concept of chiropractic. Otherwise, chiro and osteo they are hundred and thousands of year old. Even Ayurveda there is marma therapy, which is like a chiropractic and manual therapy. China also has a documented it long back 2000 3000 years back. Same with uh, other old pathies, they have a caro in their caro already was there. So basically manipulation. Now they are using a chiropractor. The term chiropractor and the DD Palmer has helped in organizing a full course on chiropractor. Same with Andrew Taylor Still. So Dr. Still is a first osteopath. Is MD medicine and a physician and surgeon, and he was the founder of osteopathy. So, basic chiropractic are nothing but is just alignment of your L4, L5. Uh, Sorry, this is a L4 correction techniques. So, chiropractic is nothing but alignment, aligning the pelvic and uh, pelvic and aligning the whole pelvic and spine. Just okay. So, chiropractic is nothing but aligning the pelvic and spine or giving an anatomical position back to the joint. So to my patients, what I explain simple is uh, shoulder joint has a typical anatomical position given. If the position of humerus or scapula is not in position, then it will not function properly. So either the muscles will become weak or tight, or the shoulder will start paining. So if you correct the position of shoulder, then it will perform better. Similarly, if you correct the position of L4, if L4 is rotated and right or left, or it is anterior or posterior, or tilted right and left, so it won't work in synchrony with the other lumbar vertebra. And this whole chain can lead to the neck. So and patient right from having a simple localized pain or restricted rotation or a radicular pain to the neck problem. Anything can be happen because of the one segment which is not in synchrony with the others. If you correct the lumbar vertebra, other spine will automatically get corrected. So this is the concept of chiropractic. They practice the short lever manipulations, and osteopaths they practice the long lever manipulations. So long lever manipulations, since the control is far from the fulcrum, the force is far away, so they are not very organized or controlled manipulation. That's why osteopathy people they don't practice more of manipulation, they practice more of soft tissue release. So MFR is basically derived from osteopathy. Then muscle energy techniques, they are basically first derived. We have also learned it from MAT is from osteopathy. Then craniosacral therapy is from osteopathy. So many physiotherapy techniques actually they have been derived from osteopathy and vice versa. So osteopathy we focus more on releasing the soft tissue fascia, especially pelvic fascia, pelvic diaphragm, lumbar diaphragm, then abdominal fascia. paraspinal muscle spasm. So very good techniques in myofascial releases are there in osteopathy. Similarly, muscle energy techniques, MAT, they also craniosacral therapy. Then they have a cranial mobilization, sacral mobilization. So lymphatics, they have a separate chapter on lymph drainage or lymphatics from osteopathy point of view. So there are good techniques where which can learn from osteopathy also. So both school of thoughts they says कि whole don't just treat the affected part but correct the whole body. So whole body adjustment, not just individual affected part. And as I told you earlier, the earliest record was 2700 BC. So it's nearly 4,000, 5,000 year old techniques. You can just not say कि it is just any part of science. We can always learn. So after releasing, then correcting, now the our main part is exercises, core strengthening. So in core training and strengthening, there is a new concept uh, developed, and in India also now classes are being organized on DNS, that is dynamic neuromuscular stabilization. Dynamic neuromuscular stabilization basically, uh, the basic principle of DNS is they follow the milestone of a child. So how the baby develop. See, nobody needs to teach a baby how to turn from right to left, how to go from supine to prone, then prone to back extension, then prone to crawling, the crawling to kneel standing, then standing and walking. These are inbuilt things, and these inbuilt things are the ideal, and they are stored in our conscience. So they are stored in our subconscious mind. But over a period of time, we forgot that ideal patterns and we develop the abnormal patterns of going to one side, sitting, standing, and walking. So if you correct these patterns, if we reteach the person okay, how to do the normal things which we are doing as a kid, then most of our problems can be solved and body will perform optimally. So two basic criteria they follow. One is the breathing pattern. So diaphragmatic breathing. We generally go for apical, short breath or thoracic breathing. Then a diaphragmatic breathing. So diaphragmatic breathing is important. And second is the milestone patterns. So this is how it will happen. So diaphragm, as you know, the origin of where the diaphragm is attached is on the lower ribs. So if diaphragm is not properly supported and your pelvic floor is also not properly stabilized, then the abdominal sacking. So we can see in this diagram, uh, we can see in the diagram how the patient's posture is affected. This is because of improper breathing pattern. So the ribs will be anterior and pelvic also will become, and the ribs will become posterior and ribs and pelvic will be anterior. So there will be no intra-abdominal pressure, proper intra-abdominal, intrathoracic pressure, and this will affect the back spine function. So what should be the ideal posture is the ribs should be properly neutral or anteriorly, and the pelvic should be stabilized. So this will give a typical ideal intra-abdominal and intrathoracic pressure, and this intra-abdominal intrathoracic pressure also create a kind of compression and distraction at lumbar level and for the whole spine. So this movement while breathing, the spine is getting compressed and decompressed, helps to give better nutrition and manage the intradiscal pressure. And this cause this keep the spine healthy. So DNS here also the same diagram shows the good postural stabilization pattern, a good breathing exercises, typical diaphragm breathing exercises, and along with the milestone training exercises. The DNS has a excellent results, and we need not teach the patient 10-15 exercises. Only 2 or 3 patterns are sufficient for homework. So generally we give mini strengthening exercises to the patient, releases, stretching. These are good in an acute phase, but for longer period, nobody will do so many exercises. So why I prefer DNS is we can teach only 2 exercises and ask the patient to practice that 2 exercise only. So patient will do it for a long term and they will remain pain free in a long term basis. So that's how we have developed a concept of integrated manual therapy. So proper clinical assessment followed by a proper diagnosis, then very good release technique, introduction of various myofascial techniques, muscle releases, fascia releases, ligament stabilization. One more concept which I forgot to mention is the ligament stabilization, which is a osteopathic concept where they help in stabilizing the ligament. So we have a joint stabilization, especially and again a ligament balancing. So ligament balancing techniques, then followed by a good biomechanical correction, postural correction, which we can do either with uh, manual therapy, McKenzie, Maitland, or I personally I practice more of Mulligan and Maitland than McKenzie. So Maitland, Mulligan, and if required, a chiropractic corrections and some osteopathic techniques, so followed by good strengthening protocols. So not only your DNS, we give core training also core strengthening, and then a generalized strengthening protocol, which muscle to strengthen and which is not. See, strengthening doesn't mean कि you strengthen everything. You have there are few muscle which are overacting, overreacting, and they are extra strong. So if you further strengthen them, they will create more problem. So we have to finalize which muscle are weak, which muscle are tight. So release the tight muscle and strengthen the weak muscle. That is the simple logic. So exercises and so and then few things like ergonomic advice if related to their profession. It gives a complete package to the patients, and believe me, they are excellent results with if you follow these few simple steps. So to conclude, what we have learned is the patient history says you many things. So where is patient? When? Where is the pain? When is the pain? What are the aggravating factor? What are the releasing factor? And what things causes when the patient is having a radiculopathy or localized pain, and especially night pain or after work during walk. These all are give you many more knowledge. So proper clinical history. You should also rule out some history of trauma and never ever hesitate to uh, go for advising X-ray and MRI. If a patient having low back pain and radiculopathy which increases with walking, we should easily write the MRI. If patient is having pain in forward bending or back extension or particular specific movement, and on assessment you are seeing that there is local tenderness and lumbar vertebra, one of the lumbar vertebra or is anterior or posterior compared to other, and there is a tightness also, there is a tenderness also, then there may be chances of listhesis. You should always go for an X-ray. And how to prescribe an lumbar X-ray? So LS X-ray, AP, lateral में flexion and extension both, because our aim is to look for the stability, how much the segment is moving anterior and posterior. So proper diagnosis, never hesitate. There is no problem in prescribing X-ray or MRI. Then after finalizing the diagnosis, treatment, 3 simple lines I told you. release the tight muscle, strengthen the weak muscle, do biomechanical corrections, manual therapy, chiropractic or osteopathy, whichever is more useful. And in home program, give DNS and strengthening exercises. And see, there are a lot many good modalities are there to help the patients reduce pain. So you can always equip yourself with machines which are helping to do MFR. So you can give either ISTM or manual MFR or matrix therapy or shockwave to reduce the spasm and trigger points. Dry needling also is very good in releasing the trigger points. Decompression is coming up with the new things. If you want a very high level practice, you can go for all. Since I'm practicing in a hospital and my clinic is also there, so we have tried to have as many things as possible. But in our individual clinic, we can select two, three good machines which are very helpful just to have a competitive advantage. Why? Otherwise, I am a firm believer in manual therapy. We can reduce the patient's pain without using any modality. But to have a competitive advantage and to give a better care, we can always go for two, three modalities. So this is the thing which I want to say in a differential diagnosis and treatment. If there are any question, we can discuss that. You can type also if you want to ask any question. Can So there is one question was in pregnancy with low back pain, can intervention can be given? Yes, yes, we can give. If there is low back pain, you can definitely work on releasing the muscles and uh, see, last week only in my OPD, one lady came. She was her second trimester, 22 weeks of pregnancy and acute pain. She has taken many painkillers. She had even got admitted for the pain, but her pain was not going. And once I released the cortitus lumborum, which was very tight, in a single setting, her pain was gone. So very good results in pregnancy, and it is safe. It's not a good. What cupping therapy I told you is not that wet cup or something. It's cupping therapy just for MFR. You suck the cup and give MFR. I've used for that only, not for the dry cupping or whipping. So, yeah, one question by this, sir, if what if the patient is complaining pain after spine surgery during walking? So, most of the time, the surgeon, that's what I've told you. Okay, if MRI shows the PIVD, doesn't mean the patient's pain is because of PIVD. In my setup also, in my hospital also, I'm working with great spine surgeon. They do operate the patient, and later it turned out the pain was simple because of piriformis. So check the muscle, piriformis or IT band or cordatus lumborum or gluteus medius. The pain will definitely reduce. That's why my surgeon they are very fan of physiotherapy because we get their even wrong surgery, unrequired surgery also we can many surgeries also we can avoid, and even after post surgery the patient can definitely be treated. Then okay, there is a hip synovitis in first trimester. How to treat it? So we are discussing low back, but hip synovitis. We have to see what is the cause. But even the mobilizing the hip and giving ultrasound or a laser there, laser should avoid. But ultrasound we can give definitely, no problem in giving ultrasound there. And basically, you can give a small grade 1, grade 2 Maitland mobilization and with Mulligan with lumbar belt, Mulligan belt and simple strengthening. So, is for low back pain is better to choose treatment-based classification or McKenzie? So, to be frank, McKenzie, I have practiced more of Mulligan and other technique than McKenzie. How do you diagnose on cauda equina syndrome? Is basically what the patient is. What are the patient's history for cauda equina? What are the you go and read what are the common symptoms for cauda equina. So this is a typical clinically only you can diagnose cauda equina. Best treatment for ankylosing spondylitis. Which stage patient comes for AS? Okay. So if it is in early stage or even in late stage also, good MFR, mobility, swimming, and whatever simple segments available, we can even do correction there also to keep the uh, joint free and mobilized. So the more you mobilize, the better you can treat the AS. See, chiropractor is anything is temporary. Okay, if patient does not do any exercises. If you correct the tight structure today, patient will come with the same problem tomorrow again because you have not released the muscle. So why the spine is rotated to the right or left? Because one side of segment were tight. That side the spine is rotated. So even if you correct the spine, the muscle is there which is tight, will again take it back. So release the tight structure, correction, and then strengthening. Then it will become a permanent. That's why chiropractor are not a good. They only chiropractic will never give you a result. Patient will the pain will come back immediately after 2 3 days or even in next day. But it gives you instant relief. So if you release the patient properly, then do correction and then strengthening, then the results will be long term. Treatment for spondylolisthesis. So spondylolisthesis, as I told you, uh, is totally depend on the stability. Either the spine is hypermobile, it is moving excessively, or it is stable. And a stable spine, a good core strengthening, small amount of correction. Yes, listhesis में corrections कर सकते हैं. करेक्शन से भी हेल्प होता है मैनुअल थेरेपी एंड एक्सरसाइजेस विल गिव अ गुड रिजल्ट फॉर स्पॉन्डिलोलिस्थेसिस बट इफ देयर इज नो रेडिकुलोपैथी or claudication but I have treated patients with claudication with simple manual therapy and with good results. We are is there any chiropractic RCT published in related with the Indian context? So we are not that there are many there are studies available but since we are learning how to publish papers now. So there more studies will come in future. How to differentiate the low back pain of quadratus lumborum, tightness and kidney issues. So yes, it is a good question. But kidney will have a very acute severe pain, and it's generally it will be associated with some urine issue. There will be difficulty in passing urine because of our pain while urination. And quadratus lumborum, there will be a typical tenderness, and you release the tenderness, patient pain will reduce. How to differentially diagnose suspected back pain with spinal metastasis cancer? See, always think simple. Uh, generally, it's only the CT scan or MRI which will show you spinal metastasis. You cannot do diagnose it clinically. So very few chances, 1%, not even 1% will be a chance of spinal metastasis. Metastasis that means patients who might be having any other cancer earlier. You can rule out in the history. And it will be a localized pain in spinal metastasis also. No? There is a chances of vertebral collapse. So there will be a localized pain and then a radicular pain. But X-ray, MRI and CT scan will help you. Mechanical low back pain and posterior deviation pain are same. Yes, they are same. But in deviations, there will be specific movement which will be restricted. The patient may be having pain on one side and free on other side. patient having night pain can be due to red flag of spine. Say 80% of the times, 80-90% of the time is muscular with followed by stress and some psychological component. Very rare it will be a red flag. So claudication, sir, can you explain about claudication and its treatment? So claudication, you can see the pain increases as the patient walks and he needs to rest after walking few distance. So we have to look out what are the cause of claudication. So if there is a listhesis, okay, or it is because of ligamentum hypertrophy. Okay, so canal stenosis is because of what? Canal stenosis is because of listhesis or because of the ligamentum hypertrophy. If listhesis is there, which is not that much unstable, you can correct it, you can get the result. But if it is because of ligamentum hypertrophy or severe root compression, then it requires surgery. Can you explain the grade of care with IFT? I did not got this uh, question, but IFT we generally give for what? For some muscle release, reducing some spasm and pain get mechanism. What type of treatment we can offer for seizure and low back pain? Pelvic floor rehab. Pelvic rehab, it is it will give you a good results in ways. If right QL is tight, so QL is generally associated with same side gluteus medius tightness also. So you follow the tenderness, then you go down, there will be a tenderness along the iliac crest, just below the iliac crest line. That shows the gluteus medius is also tight. So an opposite side, you look for the iliopsoas also. And okay, uh, any so what can be the reason of low back pain after lifting the weight? After lifting the weight, it's increased intradiscal pressure. That is the most common. Increased discal pressure. So in response, the other muscle will go in acute spasm, or there will be a small PIVD. Okay, and so swelling around all over spine. So नहीं ये तो all over spine swelling है. There will be some other issue. Look for that. Treatment of spondylitis. That means some infection is there. So spondylolisthesis is fracture in the spine. Spondylitis, that means some infection. All can be chances of inflammation or infection. So what is the main difference between root or cord compression? So root compression will give pain on right or left side. Cord compression will give pain on both the sides. So that is a difference. If patient is having bilateral pain, that is claudication. That shows a cord compression. In spinal canal stenosis, cord compression will be there. Facial joint orthopathy or root compression, patient will have only one side pain. Hope we have answered. I have answered all the questions. Uh, it's good interaction. I'm getting so many questions. Generally, people they just listen and go, but too many questions came. Pain after lumbar puncture in male. Lumbar puncture in male, we can so maybe the lumbar puncture won't cause pain. Pain will be there earlier. And because if lumbar puncture is gone wrong, they may touch the nerve root. That's it. But it will go after some time. So look for the cause of pain. It is just a patient's assessment. After doing lumbar puncture, he develop a pain. Anything specific can be done after failed epidural steroids. That's what I'm saying. Failed spiridural steroids, that means look for the cause. Don't go for the treatment, what treatment they have given. You assess it from the beginning. What could be the cause of pain and how to treat that pain. Steroids they generally give if there is a root or root compression of PIVD, or there will be facial orthopathy. So look for the cause of pain and you can release. Don't see, most of the time we get confused. Okay, patient has tried so many things, and that lead us to thinking more. Keep it simple. Treat the patient from basic only. Don't go more in detail. So now, so what is the main exercises for low back pain? Again, uh, look for the weak muscle, strengthen the weak muscle. That is the main exercise for low back pain. So thank you everybody. Thank you so much. Thank you all the participants for having such a lovely discussion.
Yeah, thank you. Thanks a lot, sir.
Thank you so much, sir, for giving me an opportunity to present to be here.
Thank you for accepting, sir. Uh, Thanks a lot. And regarding the certificate now, Dr. Saurav, are you there? Yeah, so this is the certificate code. This is LB7, and you can WhatsApp to 9066 990059. Just you have to write LB7. This is the certificate link. And just wait for 2 to 3 minutes. Once you submit the form, then your certificate will be in your mail. It is LB7, not LV. It's LB7. Yeah. Now only WhatsApp to 9066 990059. If you receive Dr. Saurav,
Yes, sir.
please proceed.
Yeah, like those who want to know, once again I'll explain. So code is LB7, no space, sent through WhatsApp to 9066990059. I would repeat, it should be through WhatsApp only. Other thing, don't change your case letters. It is a uppercase letter LB7. No space, nothing. Send to 9066990059. Another 3 to 4 minutes it will be waited. I'm putting in the chat also. And you have any question, you can put in the group also. Those who have got the certificate, please put in the chat box like you have received it. So once you send the code, you find a link, you put your complete name, later name correction won't be allowed. Put your complete name and submit after that information. You will receive your certificate in inbox within a minute, or it might take few minutes also, but sometimes it comes to the, yeah, you have got it. Thank you, Tarun. So sometimes it comes to the spam box as well. So please check over there as well. So those who have got certificate, kindly put in the chat box. So another 3 minutes it will continue. Thank you, Rajesh. Thank you, Mudit. Sending for multiple times. Once you have sent, just wait. Your link will come to you. Thank you, Shruti. Thank you, Vijay Krishna ji. Good to see you today. Thank you, Kaumudi. So it's LB7, uppercase letter, without a space. Thank you, Akhil. Thank you, Vikas. Thank you, Constantino Samsila. Thank you. Okay. Thank you, Saida. Anybody has any confusion can ask only in the chat box now only. Later, nothing regarding the certificate will entertain. Thank you, Rajiv ji. Now, for next event, you can always register. Dry needling is going to happen soon. So you can always send the message and get it. And get the information. You will get the discount as well. Thank you, Rajan. Thank you, Patra. Thank you, Romi. Thank you. Thank you so much. Thank you, Rajan. MRA number 9066990059. The same number is a MRA number. You can always contact on that number for the upcoming course like dry needling and foot, everything, foot evaluation. Including this course also, it will be like we will frame up the course with sir and then we'll let you know about it. Email box not received. Okay, fine. Please check it in your spam box, Ritika. MRA number 9066990059. The same number you are sending the code LB7, uppercase letter, no space, LB7, numeric 7. Ritika, please check in your spam box. Don't send multiple times. Thank you, Parvati. Sorry, Pravati. So another 1 minute. After that, the display will be off. LB7. Send it to 9066990059. Only through WhatsApp. Thank you, Asraf. Thank you, Serene. Sir, I think another 30 seconds we can stop the display. Most majority have got it. Thank you, Nikita.
Sure, sir.
Thank you, Nick. Thank you, Jacob. Thank you, Radhika. So its display
Okay.
is stopped now.
We
And
can wind up.
thank you so much. Yeah, thank you so much, Farooq sir. And thank you, CEO sir. Thank you, whole team. Thank you, all the participants.